Hello and welcome to lectures on cardiac morphology and congenital heart disease. This video is on complex anomalies part 1, total anomalous pulmonary venous return. So we'll be looking at samples with total anomalous pulmonary venous return, the coronary sinus type with a small left ventricle, and then we'll look at total anomalous pulmonary venous return, the supracardiac type with a retrobronchial vertical vein in the right isomerism, and then followed by total anomalous pulmonary venous return, the infracardiac type to portal vein. And lastly, total anomalous pulmonary venous return, the infracardiac type to common hepatic vein. So let's start with the first specimen. We're looking at the right ventricle, the left ventricle, the pulmonary artery, and the aortic arch. And here's the ductus arteriosus that connects the arch with the pulmonary artery. And this is on the left side, the left pulmonary artery, and the left pulmonary vein. If we are to rotate the heart to the right, we can see here the left atrial appendage, and this appendage markate the coronary sinus. The coronary sinus is located in the left AV groove. And in fact, it is here where the persistent left superior vena cava drains right between the left pulmonary vein and the left atrial appendage. And we don't have that structure here, but we have the remnant of it, which is the ligament of Marshall or the vein of Marshall, as you can see. So in this case, we see that the pulmonary veins, all the pulmonary veins, are draining into the coronary sinus. Now, if we flip the heart completely, we can see all four of pulmonary veins, the left lower, the left upper, and the right upper and lower, all join together and drain into this coronary sinus. And then this coronary sinus opens into the right atrium and then into the right ventricle. So the repair for this is to actually separate the wall that divides the coronary sinus with the left atrium. It's rather a simple procedure. Our gifted surgeons will create a communication between the coronary sinus and the left atrium, similar to an already existing lesion that is called coronary sinus atrial septal defect, or unroofed coronary sinus. So the surgeon will actually unroof the coronary sinus, and then at the final stage, they will close the communication between the coronary sinus and the right atrium, therefore committing all the pulmonary venous return to the left atrium. What's missing here is the cardiac venous return that mixes with the coronary sinus flow and the pulmonary veins going back to the left atrium. But this is such a small amount that does not cause cyanosis or hemodynamic significance. Now, if we flip the heart back and look at the right atrium, we will see that the orifice of the coronary sinus is very large because of the persistence of the pulmonary veins. It is through this orifice that the surgeon can actually perform this procedure by unroofing the coronary sinus and then in the end closing this communication to the right atrium. Or it can be also done through an atrial septal defect, as you can see here, where the surgeon created an atrial septal defect, and it is through that defect that the surgeon would unroof the coronary sinus and make that communication to the left atrium, and then come back and close the communication between the coronary sinus and the right atrium and close the atrial septal defect. This is actually the most common type of total anomalous pulmonary venous return, and we will move on to the next more common type, which is the persistence of the anomalous pulmonary venous return to form a vertical vein that goes superiorly and connect to the anomalous vein to join the right superior vena cava, forming a figure of 8, so to speak. Sometimes there will be a complication where this vertical vein can be in front of the bronchoarterial tree on the left, and then it would connect to the systemic venous return that way. However, in some occasions, this can be in between the left pulmonary artery and the left bronchus. So the vertical vein is running in between the left pulmonary artery that we see here and the left bronchus, and can be compressed by these structures. And in that way, you will have an obstructive pulmonary venous return. And sometimes it can be running behind the bronchopulmonary tree, as we will see the next specimen. So this is a case with a retrocardiac vertical vein. As you can see, we have the silicone. If we lift the heart and look from behind, you can see that the silicone casting is filling all pulmonary veins. And you can see that there's no dilation. This is the left pulmonary veins, and these are the right pulmonary veins. And you can see there's no dilation in the confluence. So that means there's no obstruction in that vertical vein that was retrocardiac or behind the bronchopulmonary tree. If we turn the heart around and got rid of all these labels. By the way, the heart doesn't come with these labels. We put them on. We see that this is the vertical vein, and it's going from, and this is the descending aorta coming down. This is the right bronchus, and this is the vertical vein behind it, going to the SVC, to the right SVC, that drains the head and the upper body to the right atrium. Oops. Okay. So that's a retrocardiac vertical vein case. Now we're going to show you a specimen of the total anomalous pulmonary venous return of the infracardiac type. So here, the pulmonary veins, once we remove the labels, we will look from the front, and we will see that these are the left pulmonary veins, as you can see them, upper, lower, and then the right upper and lower pulmonary veins forming a confluence. But actually, it is easier to see them from behind, from the posterior aspect. So if we move the specimen around, we can see the trachea and the main bronchi, and then the pulmonary veins. So we can see the right upper and lower pulmonary veins, and the left upper and lower pulmonary veins, forming a confluence. And this confluence is draining inferiorly through the diaphragm into the liver at the site of the portal vein. So it joins the portal vein as it enters the liver and form a sinusoid as it enters the liver. Here's the sinusoidal communication, as you can see it. So this is, by definition, is an obstructive total anomalous pulmonary venous return, because this sinusoidal communication is usually obstructive. This next is another total anomalous pulmonary venous return of the infracardiac type. However, the pulmonary veins do not drain into the portal vein. However, it drains directly into the hepatic vein. This is the orifice, the tiny orifice that you see here is where the confluence of the pulmonary veins. You can see here the right pulmonary veins, and from the other side, the left pulmonary veins. We will flip the specimen in a second and show you from behind, which will be easier. So once we flip the specimen and look at it from behind, you can see this is a descending aorta. We don't need that. So let's look at the pulmonary veins. So this is the left pulmonary veins, and these are the right pulmonary veins, and they are joining together to that confluence that drains through that very small orifice into the hepatic vein.